Hey, what's up, everyone? Welcome back to Exploring Places Unknown. I'm your host, Trey, and today I have a good friend, colleague, instructor, master, savant, Mr. Dean. And today we're going to talk about EMS, which stands for Emergency Medical Services, if you've never heard of that. So today I'm really just kind of picking the brain of Dean. He's a licensed paramedic, critical care paramedic, and we want to talk about EMS and mental health. So, Dean, how are you doing, man? And welcome onto the show.
I'm doing great today, Trey. Thank you for having me out here, man. I always really appreciate having conversations with you, and the fact that you invited me on your podcast, man. It's great.
Yeah, I figured you were very knowledgeable in this field. You were one of the first people I met when I came to the job, and I was like, man, you know what? You have a lot to say. And in our interactions, it's kind of in passing when we talk. And so I kind of just wanted to spend some time with you and find out more about you and how you do everything that you do, basically, man. So what inspired you to get into EMS?
So I always wanted to help people. I was actually having a kind of a hard go of it after high school, going into college, not trying to figure out what I wanted to do. Originally I was going to school for engineering, did a little bit of healthcare wise and that, and it came to a point where I just don't know. So I had a lucky break, joined a volunteer fire squad back in 2015, 2016. One of the lieutenants there was the lieutenant of the local EMS agency. I asked him very bluntly, hey, are y'all hiring? He's like, yeah, we are. You have your EMT, emergency medical technician. I'm like, I don't, but I'm willing to get it. So moving forward with that, went to the interview, passed with flying colors. The company that I worked for in my hometown in Pennsylvania set me up with basically paid for me to go to school. And then during my training and during my continued education, they paid for me to go to school as I worked for them. So it kind of just was my quick break into EMS.
So they paid for you to go to medic school?
They paid me to go to EMT school, actually.
EMT school, okay. And you know what they say, for those that don't know, EMT is emergency medical technician. That's the very base level of EMS, basically. There's different tiers, with obviously paramedic being the highest. So, what they say is that EMT is like your entry into emergency medical services, and it's the hardest. So if you can get past that hump of EMT, you're pretty much good to go. I mean, it gets more challenging the higher up you go, but yeah.
It's definitely a lot more knowledge base that you need to become an advanced EMT or a paramedic. That entry level, though, it's where most of everything starts. When you get into the job, you're green. You have really no idea what you're getting yourself into. Moving forward, become either a EMT, an advanced emergency medical technician. That allows you to do a little bit more of the skill side that you would see a paramedic do. And then you get to what Trey and I do is paramedic. So we're at technically, it's depending on what state you're in, it's the highest level of emergency care provider you could be without having to go into the hospital setting.
So we're really on the front lines. When you dial 911, we're the people that show up. Now you may have two EMTs. If you want to break that down for the audience, BLS versus ALS.
So BLS versus ALS. BLS stands for basic life support. I know that sounds, we all know what basic means, right? But being a basic or being an EMT isn't as basic as what we expect it to be. Their job is to evaluate the situation, get in there, get either themselves or the paramedic to the scene in a safe fashion. They're there to assist the paramedic or to treat the patient by themselves. Normally, it's not life-threatening scenarios that the EMTs are put into for the patient or themselves. They great for trauma care and for general medicine. ALS, advanced life support. That's where the paramedics come in. They're more the clinicians, right? So clinicians being the people that take care of you, like doctors in the ER. So how do I put this? They're more of the thought people. That's the easiest way I can describe it, right? The main difference between a paramedic and EMT is the knowledge that we have. It's the why versus the how. As an EMT, your question is, how do I do this job? As a paramedic, the question is, why do I need to do X, Y, and Z to get the situation that get the solution that I want?
Even though we're speaking about your personal story, I feel like this is also an educational episode because I think a lot of the public aren't aware of what we actually do and why we do the things that we do. So hopefully, I'm hoping that in this episode, we'll teach people, okay, when I call 911, this is what I'm expecting. And sometimes people may call 911 and they're like, well, why aren't they doing this or that? Well, it might be based on who's on the truck. Is it a BLS truck or is it an ALS truck? So, Dean, did you have anyone in your family that participated in the medicine or anything like that?
Actually, I did. I didn't even know this at the time until I became an EMT and paramedic. But my uncle, back in his youth, living in Florida, was a licensed paramedic for the state of Florida. My uncle, we call him Uncle Kenny. He's like second cousin, third cousin. I'm not entirely sure the exact where he sits on the family tree. He was a firefighter in Florida as well. So I had two members of my family that are like, this is awesome. This is great that you're going to be in EMS and fire. But there was no one really directly involved with my close family who was in EMS, fire, or the social services.
And I spoke to you briefly, and you said you just got off shift this morning.
Yes, sir.
So what does that look like for you? When you get home, how do you manage stress and everything?
So it all depends on what I'm feeling during that day. So I have about a 2-hour ride from where I live to where I work. I stay on shift for an extended period of time. Most of us do. I think you work 2 weeks on, 2 weeks off, or a week on, week off. Yeah. That's not, oh yeah, we're doing 12 hours a day. That is 24 hours a day, 7 days a week, 5 days a week. I currently work a 72-96 schedule. So I'm 72 hours on, 96 off with I throw in the 24-hour shift here and there when I can. So I just came off a 96-hour shift this morning. On my way home, I was listening to audiobooks. One of my favorite book series is He Who Fights with Monsters. I'm on book 10. They're on book 13 right now. But I was just chilling, listening to that audiobook on the way home, just trying to center myself after the craziness of this morning. I feel like I'll start talking about a little bit of that a little later during this. But yeah.
Yeah, one of the things I've learned too is, especially if you have the family dynamic and you have kids and you might have a spouse or significant other, I think a lot of times they don't realize what we're carrying or what we've seen or what we've dealt with at work. And then when we get home, they expect us, to just be normal. And I spoke about this on my last podcast, but what I've learned about the mind of an EMS person is that it takes a longer time for us to decompress versus a typical 9 to 5 person that works at a job.
Absolutely, it does.
And what that means is a 9 to 5 person, they can reset after a shift and come home and, okay, they're good. For EMS, it takes typically about 48 hours for us to decompress, reset, and be okay again. And then you have to include sleep quality. That's a big thing as well for us to get back on our feet. So managing stress, family, life, and all those things, it can be a little bit more challenging. And I want to say the divorce rate for EMS is very high because of that.
Yeah, I think the divorce rate, let me actually look that up for you really quick.
It's over 60%.
Yeah, it's looking like it's between 55 to 65%.
That's high.
That's incredibly high.
And so
It's
for the
compared to
go ahead.
other, jobs in the field, firefighters they work 12 to 24-hour shifts. They do a rotating schedule, so they're home more. Police departments normally are only 12 to 16 hours maximum. So, yeah, EMS is one of those wild beasts that it hasn't had the representation because we're so new compared to the fire department or compared to the police department. You look back in history, fire and EMS, fire department, one in the United States, was originally founded by Benjamin Franklin back in the 1700s. Police departments have been around for centuries before. Think back into ancient times. There's always some type of town guard or constable or something. True modern day EMS started back in 1972 with the white paper. It was the Department of Transport paper, how EMS and emergency medical can be used to help with accident scenes and accidents in the field. So, little weird tidbit of information there, but
And the first actual way they transported was through funeral services, right?
yeah, they used modified Cadillac hearses as ambulances because they had the long enough bed and the mounting system to put in a stretcher, or what the funeral homes would use as a stretcher, right? Where they can mount the casket to basically just a steel bed, and they would just put a little bit of padding on it, put the patient on there, and transport them to the hospital.
Yeah, it's. I mean, obviously, it's more advanced now, especially the rigs and the ambulances we ride on now. It's more high tech and stuff like that. It's not as spacious, especially the ones we work on. I prefer the box truck versus the van.
Absolutely.
Versus the
Yeah.
van.
So it does all depend. There's a couple different types of ambulances that you'll see. You'll see a van style, like your Dodge ProMaster, your Ford Transit, and then you'll see your truck style. Truck styles are those Ford F-250s, Ford F-550s, big box, the quintessential ambulance, if you will. So Trey and I both work on a van style ambulance. It's a little bit tight packed, but it's definitely more on fuel efficient, and two, it's definitely better for inner city EMS because you can dip, dive, and dodge around obstacles a lot better than you can a big truck.
And so when you get off of work, so I know you said you talked about your audiobook, but are you leaving work at work? Do you bring work home? I know that's a big thing.
It took me a long time to deal with that. I used to bring home a lot. Right now, I've gotten a little bit better with it, just trying to decompress, leaving it at work and calling it there. It all depends on what happens, So diving into the mental health aspect of EMS, right? Back when I was saying I'm from Pennsylvania originally, I'm not from, I don't, we get to say where we're from, or where we're at?
Yeah, man. What?
All right.
Yeah, absolutely.
So I currently live in Texas. I moved about 4 years ago from Pennsylvania to Texas for this job. It's a wonderful opportunity. I'm incredibly happy with it. But when I was a first year EMT, I was on an ALS unit, what we called a MICUs, Mobile Intensive Care Unit. My partner and I, we were getting fuel at the gas pump for the city. We got a distress call for a unknown injury, motor vehicle accident, possible ejection. So that means that there is someone laying outside of the vehicle, or it has been thrown from the vehicle. It was called in by one of our ambulances that passed it by on the highway. So we go screaming out to them. We find them. One patient is already deceased. The other one is still alive, but barely. So my partner and I start working on him. We evaluate the situation, evaluate the patient, and come to find out that it actually wasn't a motor vehicle accident. Sorry.
Oh, you're good, man.
The patient that I was treating and my partner and I were treating was shot in the chest by a .22 caliber bullet. What had happened was the third individual in the car who had fled the scene, shot both the driver and the passenger, trying to take the car from him. We had no idea about any of this going into the situation. He's still alive, and I will always remember his face. It is seared into my memory. The last thing he did before he went unresponsive in our truck was he grabbed my arm, looked me in the eye, and mouthed, "Don't let me die." And me being a young EMT who thinks, I'm big, I'm strong, I can do this, I can save people. I'm like, I got you, man. I got you, don't worry. It was about a 45-minute ride to the local trauma center. My partner and I kept him alive for as best as we could, right? 2 minutes out, we lost pulses. So his heart stopped. We started doing CPR, got him into the hospital, and he was pronounced dead about 5 minutes later. It really messed with me. It really messed me up because, you never want to make promises to your patients. Always state fact, but never make promises. Or don't say, "Hey, you're going to be okay." That messes with you a lot more than, "I'm going to do my best. I'm going to do everything I can." When I told him I got him and he's now lying dead on a hospital table, messes with you. And my partner and I really weren't jiving all that well. We were brand new EMT, brand new paramedic, both released to the truck at the same time, put on the same truck. That was a recipe for disaster. So there was no support between the two of us. There was a lot of misinformation going around originally at the call. I had heard the cops on scene talking about, hey, they found 2 firearms, 122 caliber, 1 9mm. Secondary individual that was already expired on scene was shot in the head with a 9mm. I had saw a little bit of what's called adipose tissue. It's the fat tissue underneath the skin, poking out of a hole between rib 2 and rib 3 that we call the second and third intercostal space. And I told my partner, I'm like, "Hey, man, I think this man's been shot." And the first thing out of his mouth was, "No, he wasn't." It wasn't, "What do you mean he's been shot?" It's like, just, "No, he wasn't." It was just that definitive, "You're wrong, I'm right." And it really did bug me. But I was fine for a while. You're riding the adrenaline high after the call. Yeah, it's sad, but that's just how our bodies are designed. We're not meant to see all this, and we try to process it in different ways. So about a month and a half after the call, I'm at a party with some friends. We're hanging out. Everything's going great. I have my first flashback. I'm seeing this man's face in the back of my stretcher as we are starting CPR. And I freeze. There's, a bunch of people around me, but it's just, I freeze dead in my tracks. I have a panic attack, and I needed to extricate myself from the party. But it took me a long time after that diagnosis, not even diagnosis, I should say, after that first flashback to even start reconciling what I had seen during that call and what I had seen and did as an EMT. I ended up did go for counseling, talked with a couple psychologists, not psychiatrists. Finally, after a while, it started to help. I was diagnosed with major depressive disorder, MDD, and PTSD because of this job. And that was within my first year and a half. I've been doing this almost a decade now. I have a bunch of other different stories from, that time when I was working in my hometown. But there does come a point when working in your hometown doesn't work anymore, especially if you have all that pent-up anxiety and, better term, aggression. Because PTSD, sorry, Trey, please go. Go ahead.
And when you're working in your hometown, it's not the same because you're experiencing all this trauma. You're going to all these calls. You see the bad side of the city.
We see the absolute worst of humanity, and especially in our hometown, we can't comprehend that.
Yeah, it's like living in a alternate reality, man. And just a little backstory on me, and we don't have to go tit for tat on stories. It all affects us, I feel like, the same because we're human. And I have been diagnosed with PTSD, and I had to do some very intensive therapy. And one of the main things that helped me was learning about PTSD and how we store that information. And my PTSD had got so bad to where, because I obviously would go on all the bad regs, all the fatalities, just the smell of gunpowder or the smell of gasoline would send me off into a flashback, and it would change my mood. And I'd be around someone, they'd be like, "Man, what's going on, Trey?" Well, I'm in this moment right now.
You're
You know?
absolutely in that moment. Um, your flashback, like you're reliving it. Military professionals, Army, Navy, Marines, like they're not the only ones that experience PTSD. Healthcare workers are another huge proponent of that, and we need better mental. I think you would agree on this one. We need better mental health, just access.
Yeah.
Again,
I'm gonna give a shout out to my therapist. I go to a place called Forged in Valor Counseling, and it's specifically for first responders, military, police, fire, etc. And they specialize in what's called EMDR. I don't know if you ever heard of that, but it's eye movement desensitizing something, but it's called EMDR. And we did a few sessions on it. And at first I was like, oh, this is a bunch of BS, right? And basically, what happens with PTSD is that information is being stored in the wrong part of our brain. And the EMDR, what it does is it kind of tricks your brain to put that information in the right spot. So, for instance, I had a drowning maybe, I'll just say last year, and it really affected me. I have kids, and my patient was a 12-year-old girl. And when I looked at her, all I could see was my daughter. And that really messed with me. And so I was like, I know I don't want to drink. That's not going to help. I don't want to go party and avoid it. Let's deal with this head on. And so I got recommended to do EMDR. And I was like, okay, I'm going to go in this with an open attitude. I'm going to at least try it. And so what they did was they put some headphones on me, and she gave me like these little tappers or whatever that would beep. And it would go off, and she'd say, okay, let's walk through the call. And we did it probably, I'm not going to lie to you, at least 6 times. And by the end of it, I was able to talk about the call, no problem. And she helped me to talk about, well, what'd you see? What'd you smell? Did you taste anything? What'd you hear? And so it brought me back to the call. I was able to process it. And we kind of like turned that traumatic incident into a black and white incident in my brain. I can't explain it, but it worked. And I can talk about that call, no problem now. And so I think for us, people have this really high expectation of us just being like these superheroes that we know it, we know everything, we're going to fix it. Well, maybe sometimes we can't. And I think people need to know and understand that we're human too at the end of the day. And the best thing you can do for us coming on the scene is, okay, give us information, speak clearly. Do they have a DNR? Educate yourself on your medical condition and stuff like that. So PTSD is a really big thing. And unfortunately, some people, they commit suicide. Suicide's a big thing as well.
we had so I worked in Philadelphia, and in between my hometown and Philadelphia, that's before I came down to Texas. I worked at a ambulance company in Lancaster County, Pennsylvania. We unfortunately had an incident right before I started of one of our providers committing suicide and taking his own life due to the PTSD in the job. So that was an unfortunate thing. We've had actually a couple here within the last couple of years of working at the company we work at, Trey. And it's just, there's help out there for you. Suicide is never the option. It is a permanent solution to a temporary problem.
I also think too, I feel like sometimes people in our field put on a tough act.
Oh, it's a
or a
mask.
tough
Absolutely is a mask.
and a tough face to kind of like say, you know what, I'm good. And I feel like when it gets to that point of suicide, we more so react versus being proactive. And so one of the things I try to do is to be proactive, and actually be nice to my coworkers. And hey, do you need something? Hey, how are you doing? How are you feeling? You know, um, some people, they just bottle it all in until it's too late. And the way the mind works, I mean, you know how PTSD is. So imagine the thoughts that they hear. Well,
Just
I don't want to be here.
It's just spirals, and it's an exponential fact. Your mind does not know how to comprehend what was seen, what was heard, what was smelled. Your body, your mind, it replays and recreates olfactory senses. Like, you smell the gasoline, you smell the gunpowder, you smell the iron in the blood. That's just something that you do, even if there's nothing around. That's how powerful our minds are, especially when they can't comprehend what we saw. They can't process the information. I know Trey talked about his EMDR.
Yeah. EMDR.
My doctor did something similar but different. We had a time frame. So him and I had a phone call. It was once a week, and then it went to once every 4 days, once every 3 days, and once every other day for about a month straight. For that first week, he told me, hey, we're going to talk about this call. We talked about it. I got through the best I could. And then he's like, I don't want you to think about the call. I don't want you to talk about the call. Nothing. Just put it out of your mind. Let your subconscious work through it. 1 week later, we had another phone call, started talking about it again. Got a little bit easier. He's like, okay, I'll call you in 4 days. So, and we repeated that situation until I was able to have this conversation. And yeah, I still have some issues with the call, right? And I'm sure you still have a little bit of issue talking about your call. But there's different tools and different methods to be used to get around and help your mind process what's going on. But you need some type of professional help, I would say.
Absolutely. Bro, I can go on and on and on and on about the mental side of this, which I really love talking about this because it's like it's like the elephant in the room, so to speak.
No one wants to talk about it. We are just getting out of that phase of the macho man, for lack of a better term, but good old boy, fire and EMS, where finally we're having a lot of new youth come in, new young bloods come in, and change the aspect. They change the curve. And we're finally able to talk about this, and it's not looked as a taboo.
Yeah. And one of the big things too I've learned when experiencing a traumatic call, there needs to be a debriefing,
Absolutely.
right?
Absolutely.
Don't just experience the call and go back and go to bed or take a nap. Like, you need to be able to debrief with the people that were directly involved, because they're going to help you see other sides of what happened that you may not see. I've also learned, try not to include people that weren't directly involved, because you might give them some kind of trauma just from sharing your story, so to speak. So there needs to be like a debrief within the first 24 hours to at least get it off your chest.
We had when I was working up in Philadelphia, if we had some type of traumatic call like that, we had SISM. SISM means Stress Intervention Management, for lack of a better term, what it's called. We would have them come in, or at least be able to be on call 24 hours a day for us. Hey, there we go. Critical
I'm
Incident
certified, man.
Stress Management. There you go. That's awesome. I actually didn't know that, dude.
I went through the training to become a peer SISM counselor or whatever. So it's like a flip sheet of how to debrief, how to talk about it. Like, I've done the training. I am certified to hold debriefings because I know how much it effed with my head, just holding on to stuff, sleeping. And when you sleep after a traumatic incident, it stores that information. Like, you got to get it off. You got to get it out,
Sleep is one of those weird things where it takes your random access memory that the short-term memory that we have and converts it into long-term storage. So if you're going to sleep or you're not able to decompress and talk about and try to process what's going on right away, and then you just store that jumble of chaos, it sticks there. And that's what causes most of the problems.
So we did talk about what you do when you leave work. So how do you prepare for shift? What's your ritual? What's your routine? How do you get yourself ready for the unknown or the abyss?
So it actually starts either like the day or two before. Normally that first day after shift, I am completely out of it. The most I'll do is maybe hang around my apartment and play some video games on my computer. But that next day, I'm going to the grocery store. I'm figuring out a meal plan for the rest of the week, and I'm cooking. Cooking is my zen. It's my baseline. As long as I'm cooking, as long as I'm doing something like that, it levels me out. It gets me to a point where I'm able to like, okay, so we're good to go. I have food. I have drinks. I have food prepared. Good home cooked meals, not this expensive houses out there anymore, or any fast food. Health in general is huge. I should say the lack of healthy options for EMS personnel unless you cook it yourself or bring it from home. Trey, I don't know if you know this or not, but back before we started down on the location that we were at about 2 years ago, I was 75, 80 pounds heavier than I am today.
Really?
Yeah, I was at the heaviest, I was 330 pounds. And that's just from sedentary lifestyle because of EMS. We're sedentary half the time, right? But poor diet. Poor diet was my huge crux. High calorie, really rich food, and just having to work in a situation where we're sitting half the time. It wasn't conducive. I did make a huge change, consulted my doctor, put me on a caloric deficit diet, and I dropped 75 pounds. 75 pounds, I've kept off 70 though, within the last year and a half. So,
Are you still trying to lose weight or are you happy where you're at?
I'm ecstatic where I'm at right now because I'm actually lighter than I was in high school. But I am still trying to lose weight, but I'm doing it at a much slower pace than what I did over the last year and a half. So I'm still trying to either maintain or drop slowly. I'm not trying to, make that huge 30, 40 pound drop again. My end goal is about 220, 230. But if I stay at like 240, 250, I'm ecstatic at that. But it's all about your healthy diets. The way my doctor described it and explained it to me was as long as you stay within your caloric deficit. Now, my caloric deficit at the time was 1,800 calories. That was the maximum I was able to eat during a day. He told me straight up, I don't care if you eat 1,800 calories in ice cream or 1,800 calories in salad. Stick within the 1,800 calories and you'll be fine. And that's what I did for a year and a half and down to 270 right now. And it's great.
Man. One of the things I do to get ready for work, definitely catch up on sleep, talk to loved ones.
I call my mom every single day, or
yeah,
I
man.
try to. I honestly try to call my mom as much as I can. There are days where it's not that I forget. It's just I get busy doing other stuff.
One of the things I've gotten bit by the bug of pickleball.
Pickleball.
So I've been playing pickleball every day, and that's like my woosah. Of course, I run and do all that stuff, but that helps me to kind of reset, man, is working out. It clears my mind. It helps me to decompress all of any anxious or, worries that I may have. It helps me to decompress before I come back to work.
Yeah. Exercise is huge for that. I work out myself, not as much as I want to be honest, but
You're doing something.
I'm doing something. I'm at least active. But Trey is absolutely right. It's a centering. For me, cooking is my centering. It's getting me into that flow state, that zen state where everything is like I'm in control of everything. And that's actually the key of everything is control. During a PTSD episode or a traumatic event, you're not in control and your mind doesn't know how to handle that. So if you get yourself into a position where you can control the outcome of something, cooking, woodworking, exercise, video games, talking to family, friends, going on a walk, put yourself in a position where you can control the outcome of the situation.
Yeah, I went hiking this past weekend, about 4.5 miles, man, just out in nature. And that did wonders for me because the weather's getting good. So just even nature. Um, I think also journaling, believe it or not, man, write out how you feel in the morning, write out how you feel before you go to bed. And that way you're not sitting up trying to solve the world at midnight. Those are some of the things I do. Um, Another topic is burnout.
Yes.
How do you manage that?
I am probably not the best person to ask about that, to be completely honest. I've experienced burnout multiple times in my career. I've gotten to the exit point, for lack of a better term, was like, I'm done. I'm going to go do something else. But every time I think about that and think about, well, what else could I do? I still come back to medicine.
Yeah.
Medicine is such a rewarding career, but there needs to be a change sometimes. A complete reset of either where you're working or the location that you're at. Take a vacation. Take some time off work. I know I'm very guilty about this. I never use my PTO. I never use my time off. But taking that time off and getting into a position where you can center yourself and get yourself back to a baseline state is huge for your mental health and your performance in this job. I just actually came back off of vacation. It's my first vacation I took in over a year.
Nice.
Went down to Florida to see some friends. It was a fantastic time. The last day I was there, they unfortunately had to work. So I decided to drive 4.5 hours from Fort Myers to Cape Canaveral. And I spent the day at Kennedy Space Center, and I was able to see the Falcon 9 Heavy launch
Nice.
that night. It was fantastic.
Have you been to the NASA space station in Houston?
I have. I was there a little over a year ago. It's Kennedy Space Center doesn't compare. Space Center Houston doesn't compare to Kennedy.
Really?
It is phenomenal. Don't get me wrong. The Saturn V Apollo, I believe it was either 19 or 20 they have there. So it's the actual rocket, right? It's all done up beautifully. It has the enclosed building around it. It's awesome. But the production value that Kennedy puts into their exhibits, it's an emotional experience. For lack of a better term, it is straight up an emotional experience. They have the Space Shuttle Atlantis there. That was the last space shuttle flight and return of its entire service and career. It's the last one to fly up, last one to come down. Going through their 10-minute presentation, I really don't want to spoil it for anyone, but I'm going to because I want to talk about it. It's so good. There's a video that they play, and it's a production video, right? But they're going through, and then they're doing a whole how the space shuttle was made, but in a theatrical sense. And then you see Space Shuttle Atlantis coming down, flying through the air, and it's at a perfect bank. And then the transparency happens on the screen, and it shows Space Shuttle Atlantis in the background with it still flying through the air as the screen raises up. So you're actually seeing the shuttle still fly through a video, but it's the actual shuttle in the transparent screen.
Whoa.
It was, like I said, I'm a huge space nerd, as you can see, I'm wearing a NASA t-shirt right now, but it was an emotional experience. I hadn't been to Kennedy Space Center in over 20 years, and seeing how things changed, it was what I needed to come back to work and be able to be like, yeah, let's go do this.
Yeah, that's awesome, man. My logo actually is kind of hard to see it on here, but it's a guy standing and looking off into space, basically.
Yeah,
I love space stuff, man. And there's so much we don't know. And I think that's why I said, this podcast should be called Exploring Places Unknown. A place I would love to go to, man. I don't know if I could, is Area 51, just to see what's going on there. I don't know.
I don't know. They're hiding some stuff. You know what
Yeah,
they say,
dude.
though? It's not Area 51 that you need to worry about. It's Area 52.
Really? What's going on there?
It's a joke. It's just
Okay,
a
I
joke.
guess.
Because it's the one no one talks about, right? So, fun fact, and you can fact check me on this, but the whole Area 51 area, whatever, their military bases out in the West during the Trinity experiments and during the Cold War
Okay.
era. They're all
Trinity. Oh
military.
yeah.
They're all military bases. They're all weapon testing sites or experimental sites. So they just call them area, and this is the zone that they're in. So Area 51 is the well-known one, but there's a bunch of different other areas. There's Area 17, Area 20, and they're all different military testing sites.
Nice. You're kind of when you talked about the Trinity experience or experiments, that's kind of diving into Oppenheimer, right?
Yes, sir.
Oh yeah, man. That stuff's fascinating for me, man. It's just mind blowing.
So, like I was saying earlier, I went to college, right? And I was trying to figure out what I wanted to do, and I couldn't figure it out. I was actually going to school to be a nuclear engineer.
Dude, that's badass.
Dude, it was so much fun. I figured that out when I was in high school. It's like, chemistry is awesome. I wrote my Chem 2, my end of year Chem 2 senior paper on the difference between the plutonium and uranium bombs that were dropped in Hiroshima and Nagasaki, because that has the most documented forces, reactivity, and everything. It's like a 15-page research paper I put out on that for my senior project, but it was awesome. And I fell in love with it. I'm still in love with radiation and nuclear just history, but now it's more moved to the medicine side. Orphan source events, and different stuff like that is a whole rabbit hole we can get into at different time if you want to talk about it when we're at work. But
Do you think EMS is prepared for a radioactive event?
absolutely not. We are absolutely unprepared for any type of major biological or chemical attack. We're just, unfortunately, and that's the nature of the beast. We're not a CBRN team in the military. We're not prepared, trained, or equipped for something of that scale. Now, cool thing about Texas is they have there's a possibility of a CBRN unit, or what they're calling an RRU, Radiological Response Unit, being put up for the state of Texas for EMS providers to come in for. I'm currently a member of the IDRU, which is the Infectious Disease Response Unit. It's a completely volunteer agency for the state of Texas that if someone has what we call an Andromeda strain or some type of highly contagious, highly contractable, and highly deadly disease, we're the crews that go in the Class A hazmat suits and the big bug suits that everyone sees on TV. We're the ones that go in and take care of those patients. But there was talk about putting it together an RRU by 2026. And it should be really cool.
Nice. Were you participating in this when there was the Ebola scare a couple years ago here in Texas?
I was not. No, I just actually recently joined the team about 7 months ago.
Nice, man.
You have a couple more minutes?
Oh yeah,
talk
man.
about cool.
Hell yeah.
Kind of want to talk about COVID a little bit. I know you were working during COVID, right?
Oh yeah. Oh yeah.
So I became a paramedic in 2019. So 2019, we had about 3-4 months before COVID was really big in 2020, right? Everything changed. The whole gambit completely changed from how we handled EMS to how we were handling it then. Because it was like, oh yeah, we don't have to wear masks. We'll wear gloves when we need to, but we'll protect ourselves. But it's not really, a thing. Even though whenever you go through EMT school, BSI, scene safe.
Right.
BSI meaning body scene isolation. Basically, they're just talking about gloves. But now we're wearing goggles, masks, gloves, full Tyvek suits. When I was working in Philadelphia, the company I was working for had the contract to assist CHOP is Children's Hospital of Philadelphia. So on multiple occasions with my position that I was in Philadelphia, I would go over to CHOP and assist them with their transports. Whether that's either driving the ambulance or in the back of the truck taking care of the patient. When COVID first hit, we had no idea what was going on. We were in complete PAPR suits and not hazmat suits, but Tyvek suits with PAPRs. So they're positive air pressure systems, basically the big whole mask around your face and pressurized filtered air. It was crazy. It was bad. I learned a lot during that time frame as a paramedic. Honestly, I probably wouldn't be the paramedic I am today unless I spent the amount of time I did in COVID learning how to take care of severely sick patients. My mentor, Nick Kirshner, I'm gonna call him out on this because he's one of the most amazing people that I know. Military veteran, both Army and Marines, spent countless years working 911 EMS in Atlantic City and worked in Philadelphia, and he was my mentor before I got more comfortable as a paramedic and transferred down to Texas. But he is probably one of the best mentors I've had in EMS, along with why can't I think of his name? Rich, and when I was working before I went to Philadelphia in Lancaster County, him and I are still great friends today. Last year I was best man at his wedding.
Nice.
Him and I still talk about some of the calls we ran. So we've talked about the really bad side of EMS and how it takes a toll on our mental health, but not every horrible call is a horrible memory. Rich and I ran this head-on collision in Lancaster County. It was on the highway, a super, super foggy night. Like, we had maybe 45, 50 feet of vision in front of the ambulance. It was a sedan versus truck. They impacted each other at highway speeds. Both drivers were trapped. Rich and I started working on the driver in the red sedan. Complete crush of the car. So there was no getting into the vehicle through the doors. So myself and Rich crawled through the windows, and we're actively treating this patient inside this crashed out car while the fire department is actively cutting us out of the car with the patient. It was probably one of the most crazy stories that I have in EMS, and I still look back on it today thinking that as awesome, as crazy, I don't want to do it again, but at the same point, I want to do it again because we're actively taking care of some. And then the whole combination. I've never told you this story, Trey, but so long and short, we're there for about 30 minutes before they get the car out. My ambulance is on the northbound side. The accident is on the southbound side. We've hopped over the barrier to get to the patient. A local volunteer ambulance squad shows up, and they're on the southbound lane heading south towards Lancaster General. Rich and I look at each other. Rich is hopping in to their unit a while. My unit is still across the other side with my actual partner. And Rich goes to me, Dean, do you have a patient? I'm like, no, sir. Looks at my partner, Paul, do you have a patient? No, sir. Dean, get in. We hijacked an ambulance. Rich and I hijacked the ambulance from this volunteer squad. It was a great time. So yeah, there was 3 EMTs on that unit, 2 old timers and 1 young buck. Young buck is literally sitting in the captain's chair shaking because he's like, what is going on?
Yeah.
We're flying down the highway doing 70 in this dense fog because this lady's really, really messed up, and she survived. Rich pulled out all of his combat experience as a combat medic for the United States military, did casualty evacuation on Black Hawk helicopters. He's one of the most, between the 2 mentors that I had, I'm trying not to cuss if you can't tell.
No, go ahead, man.
Dude, they're the 2 most badass motherfuckers that I actually know on this world. These stories that Nick can tell, the stories that Rich can tell, beyond anything that we'll experience in our actual lives. But they're also amazing mentors and instructors. Like I said, I wouldn't be half the paramedic I am today without those.
And for the public, believe it or not, there's stories like this that happen every day. It's just not televised or publicized, but we truly do heroic things, man, that probably could be a Hollywood movie
Oh, absolutely.
It's just for us, we see it every day and we're doing the job, and I think it takes a special kind of person to put their lives at risk for someone else. And I wish the public was more forgiving. I know that you're calling 911 and it may be the worst day, but give us a little bit of grace here too.
We're humans. We're
Yeah.
we're human just like you and just like you. We've had those days. We've experienced those days. We've experienced those days through other people. That is literally the job that we set up to do. The lieutenant that basically gave me this opportunity, right, got me into EMS, explained it to me like this. They, as in the general public, they call us because they cannot handle the panic. We need to handle their panic for them. So if we're panicking, that's a really bad sign. And that means that the public can't transfer their panic onto us. We have to be that rock in the storm, that the ability to just be like, okay, this is what needs to be done. We need to get it taken care of. Need to go.
Yeah. And yeah, I've heard that too, but it was managing the chaos, managing or the way we handle it, it's how do you say it? It's managed chaos. We're just managing that scene. Yeah, we're managing that scene. So we may be freaking out. It's just we're composed.
Yep. I think the other term is controlled chaos.
Controlled chaos.
Because chaos itself is uncontrolled, and the uncontrolled thing is chaotic. We're there to control it and mitigate the amount of chaos that gets out.
Do you feel like with the paramedic education or any EMS education, do you think it adequately prepares us for that kind of stuff that we're going to see?
No, it doesn't. It's sad because most paramedic education, most EMT education, it's the same that we had in our high school days, our middle school days. It's teaching us to pass a test. And my paramedic instructor even told us, it's like, hey, we're going to teach you how to pass the paramedic. We're going to teach you how to become a paramedic, i.e. passing the test. It is the job of the agency that you sign on with to teach you how to be a paramedic versus it's the becoming versus being. Anyone can pass a test. It's how you use the knowledge that you gained from going through that class and how to appropriately apply it in every situation. And unfortunately, the schooling doesn't have time for that. I don't know about you, but I had a 9-month crash course.
Yeah, same.
Yeah, like it's like a paramedic program. Most of the time is a 2-year course, but Trey and I both went through a 9-month crash course right before I went through right before COVID. I don't know what Trey. When did you get your paramedic, Trey?
2019.
So we both, right before COVID, right before everything, we both got our paramedics the same year. Wow.
And I think what helped me, and for the public or the audience, I don't know why I keep saying the public, for the audience, they don't just ship us out into the field. We have to do X amount of hours in the clinical setting, and we also have to do X amount of hours in the field. So it's not like we just pass the test and, So I think that's what helped me actually become good was the field experience, like you said.
Actually being able to do the job instead of just hearing the theory behind the job. Like I know with my schooling, I had 400 hours of clinical time in the ER and on the truck my first semester. Second semester, it increased to 800 total between all the specialties. Excuse me.
800 hours. That's a lot.
800 hours, and then finally finished out with another 800 on, I think it was 400 on the truck on that last little bit. So within 9 months, I'm working 2 jobs, both as EMTs, one for a fire department, one for any ambulance agency. I'm going to school full time, 3 days a week, going through all my clinicals, all of those hours, and I'm still trying to have some type of, personal relationship with my friends and family. There's a lot of ways EMS can be better. There's a lot of ways EMS education can be better. But for what it is, I don't see how it can be better because it's already at that kind of situation where it's like we're at the best of what we can do right now.
I think there just probably needs to be more services or accessibility or more accessible services for us. And I think it needs to be broadcasted like, hey, if you're EMS, hey, come see us. I think they've done a really good job with the military. I think there needs to be something for EMS as well, just to make sure we're good. Because one of my most favorite words I love to use is resilience. And resilience for me is not that you won't get knocked down; it's the ability to get back up.
Yeah.
Right? Because we're on the
I
front
call
lines.
I call it stubbornness. I'm too stubborn to let it affect me and let it drive my being. Same with you with resilience. People call it different things, but it all comes down to the same aspect of what Trey was saying. It just, how do we continue to move on from the situation?
And, I know we've been doing it a while. I truly believe that over time, we develop like this superpower, like we get this sixth sense almost with calls. Do you ever experience that? Like, I know, like, I'm like, oh shit, this is bad. Let me go ahead and get ready for RSI or whatever. So have you developed that?
Yeah. It's something that most people develop within the first couple of years of their career. Just some people say it's a sixth sense. Some people saying it's just processing the information that you're seeing and equating it to past experiences. But yeah, that's just hearing something come over the radio of X, Y, and Z at this location, and you're just like, that's not going to be good. And you just know off the top of your head that this is not going to be an easy call, and you're going to have to put in a lot of work. Last night we had on my last shift, we just had a cardiac arrest. It's unfortunate that I actually knew the person because I treated him a month prior when he had his last cardiac arrest. He was that dude, the assault patient that coded on my truck twice, and we brought him back. He unfortunately passed last night.
And he didn't have a DNR. Was he on hospice? Something like that?
38 years old, dude. He's a couple years older than you and I.
Wow.
Don't do drugs, kids. It's bad.
Yeah.
Seriously. But yeah, it's the unfortunateness of it. It's like, I personally knew the man. He hugged me 3 days after he left the hospital when I brought him in. It was about a month and a half ago. So I'm still trying to process that information right now.
Yeah. Yeah, that's a tricky one when you know them. And I think that's why I don't work in my city or anything like that. Even though where I live, it's way bigger than where we work. But yeah, I don't know. I've never experienced that, so to speak. If anything, it might be a patient I've ran before, but no one I knew to that level, I guess, where you working them, bringing them back kind of thing. Um, I haven't asked you, but what is a typical workday? Like, what are the pros? What are the cons?
Typical workday for us, at least for my unit, we start at 8 a.m. We're that kind of that middle truck that helps with shift change. So we start a little bit later than most of the other crews, but it gives them time to get in service. So when we're there the next day, we're in service while they're trying to get ready. Starts at 8 a.m. Between 8 to 8:30, we're doing truck check off, making sure we have all of our equipment that we need to get done for the rest of the day, for the rest of the shift. After that, we head to post. So the agency that we work for, we do what's called a posting or system status management. Basically, we go to different locations of high call volume, and we are actively waiting for a call to drop in the area to cut down on the time it takes for us to get there. So as your partner in the rig that's fully stocked, should be fully stocked if you did your job correctly, and then you're waiting for a call. Now, we have a lot of downtime in EMS. It does depend on how busy the system is or how busy the day is, but we have a lot of downtime. So being able to adequately manage your time through that, grabbing a nap here and there, making sure you have something to eat, chatting with your partner, playing on your phone, watching a YouTube video or a movie. Like, it's just, you're trying to get yourself to the position where you are physically able to go on the next call, even when you're dog out, drag out, tired.
And so for a an ambulance unit. Me and you both work on ALS unit. What are some of the things that we carry, just so the audience can know?
So in an ALS unit, advanced life support unit, we carry, I think in actually the state of Texas, we're actually considered a MICU, to be honest, mobile intensive care unit. We carry most of the stuff you'll see that the ER is using in the field for resuscitation and for emergent care of your patients. So we have medications to help you breathe better, and medications help your heart function better. Medications to, if you're having a heart attack, to help mitigate that until we can get you to the hospital with a cath lab. We have a defibrillator unit, cardiac monitor. It's a beautiful piece of equipment that we carry that can do 12 lead ECGs that we can interpret ourselves versus having to send to a cardiologist to interpret for us. Blood pressure, you monitor your blood pressure, your pulse ox, the amount of oxygen in your blood, your capnography. End-tidal capnography is how much carbon dioxide you're breathing out at the end of the exhalation. So it's something that we can use to monitor how well someone's breathing and how well the gas exchange in the lungs is working. We also carry some more specialty equipment. Now we have the stretcher, we have, the spine precaution boards, back boards, neck braces, all that stuff. Some of the weirder stuff is the KED board, or the KED, which is this weird vehicle extraction tool. I've actually never used it to get someone out of a vehicle, but I've used it for I've used it for hip immobilization, and I've used it as a device to help pick someone off the floor in a tight situation because it has grab handles on it. Some of the more specialized equipment that we carry are laryngoscopes, so things for intubation, which is placing a tube in the trachea, where we breathe from, into the patient to help them breathe or take over respirations for them. Our unit's a little bit more specialized than others because the company we work for, we have ventilators, IV pumps, and special different medications that you wouldn't see on a normal unit. We carry RSI medications, which is rapid sequence intubation, which is your sedation, paralyzation, and intubation.
So you're telling me we could paralyze somebody?
We absolutely can paralyze someone. We shouldn't do it while they're awake, though. We should do it while they're asleep. But we have all these tools that you'll see in a hospital. Now, we don't have the fancy stuff like ultrasound or Doppler or the big ticket items that makes a hospital. But if we're taking care of your family member out in the field after a cardiac arrest, we're doing a one-for-one recreation of what the hospital's going to do. We're just bringing it to you. We carry the same medications. We're going to give the same medications. We also carry the Lucas device on our truck. The Lucas 2 is a plunger-driven automatic compression machine. So, with CPR, you're putting two hands over the patient's chest just like that, and you're pressing firm and hard. We have a machine that does that for us. And it's a phenomenal piece of equipment, especially when it's only two people working a code until extra help can arrive. It can free up hands from doing CPR to do other things.
Oh, yeah. Talk about the IO. What's the IO?
The IO is the intraosseous. So IO stands for intraosseous. We have what's called the EZ-IO. That's EZ-IO. It is basically a little tiny battery-powered drill that we can use to drill into a patient's bone, whether that be the tibia, the shin bone, or the humeral head, to get access to the patient when IV access is not functional. It's not able to be obtained. Fun fact about IOs, humeral head IOs have a higher flow rate than most large bore IVs. So during a cardiac arrest, the position for the IO is always going to be the humeral head for me.
Left side or right side?
It honestly doesn't matter. Whichever side is less in the way. But both vascular, for both return, it's vascular return both straight to the heart is much more faster than while we were in the legs, and especially during a cardiac arrest, while we're giving epinephrine and antidysrhythmics, getting it to the heart faster is what we need to do.
That's because of the superior vena cava.
Correct.
Sitting up top, yeah. What bit of advice could you give to our audience on A, how to better take care of themselves, B, how to be prepared when you call 911, and see what to expect.
So getting on the health side, taking better care of yourselves, eating right, watching your caloric intake is the biggest thing. Watching how much refined sugar. I'm not going on a health nut craze. I still love my Little Debbie zebra cakes. Like that's just they're great. But balancing out your diet is the best thing I can think of. Getting out there, being active, exercising, taking care of yourself. Go see your doctor. If they put you on medication, it's there for a reason. I know, especially blood pressure medication, we get this all the time. People who take blood pressure medication start to feel better after 3 or 4 days. And they're like, oh, my blood pressure's fixed. I don't need the blood pressure medication anymore. That blood pressure medication is what's making you feel as good as you are. You need to continue taking your medication on a regular, consistent basis. Getting to the next fact of how to prepare, call 911. It's a scary process, right? You're calling 911 because there's something going on that you either can't handle, or someone's super sick, or your house is on fire, or there's some type of disturbance going on. Clear, concise information. Take a breath, center yourself. They're going to ask you the questions and they're going to walk you through it. But having that information be able to be on hand, I'm 29 years old. I'm having chest pain. It's in the center of my chest. I'm at XYZ address in X city. I live on the 4th floor, and no, I don't have any pets. The pet thing is another thing that most people don't even think about. Or I'm able to lock them up, or I'm just having shortness of breath, or I fell. Giving as much information you can to the 911 operators allows us to better prepare ourselves to come and help you. And then once we arrive on scene, we may need to, if you're not able to open up the door, or you're in a position that you can't help for yourself, so we may have to break in. Or if the door is locked and you have some other people that can help you, you're going to come in. It's going to be a bunch of different people, especially in our agency. We have fire department that rides with us on every call. So there's going to be between 5 to 6 people in your house that you don't know. It's a scary situation. We're all big dudes who are trying to help. And it can be scary. We're going to have a bunch of different bags, a bunch of different equipment. We're going to be asking you a lot of questions right away. We started doing this up in Pennsylvania. It's called a Life Vault. It's a pill bottle with a note in it. It's a list of history of medications, your medical history, the medications you take, name, date of birth, point of contact. And it's in a pill case, a pill bottle. And that pill bottle goes into either the refrigerator or the freezer. And at one of the agencies I was working for in Pennsylvania, that's the first thing one of the firefighters or EMTs would go and look for. If you're not able to get here, talk to us and get the information that you need to do across. So just be prepared for us to show up and let us help you. Don't try to fight us. Don't try to get into an argument with us about what we are trying to do. So all we're trying to do is trying to help you in the best possible way.
Yeah. And one thing you can do is write down your medications, put it on the fridge, and know about, if it's not yourself, if you're taking care of a family member, have that stuff ready, because it may be an emergent situation where they're unconscious and we got to start treating. And if you have that information ready for us, we can bring it with us, and it kind of helps us. But sometimes with a scene, I need to get the information and be able to treat the patient at the same time. And so it just helps when you already have everything right there,
Yeah, it's one of those things where if you have words are hard. If you have that information, I can start narrowing down where I need to treat for what, versus having to go from this list of 20 different things I'm thinking that's going wrong, and I can narrow it down to maybe 5 or 6. And I can start doing pinpoint treatment instead of a broad treatment. And that helps us with our timing and getting you to the location that you need to go, which is inevitably is the hospital.
Oh, that brings me to my next point. Destination choice. And what I mean is picking the most appropriate hospital. If it's the way I always say, or the way I like to say it is, if it's truly an emergency and I see that your vital signs are not good, I'm going to recommend the most closest facility that is able to handle that situation.
Absolutely.
No, it's not we taking you to a hospital you prefer. Like if you're having an active heart attack, I'm going to take you to a cath lab.
Yeah.
Not to a hospital Go ahead.
Not to your cath lab. I was just talking with you.
Yeah.
Not to your cath lab that's 35, 40 minutes down the road when there's a cath lab in the same town that you're in that's 10 minutes away. Time is muscle when it comes to cardiac. Time is brain when it comes to a stroke. Getting you to the closest appropriate facility in the quickest amount of time is what saves people's lives. Not by going of where you want to go, going to where you need to go. And I apologize for interrupting you, Trey.
No, dude, you're good. It brings up my next point. There's something called the golden hour, right?
Mm-hmm.
And that golden hour means us getting you the most appropriate level of treatment within that hour. It also details your likelihood of survivability as well. And so getting you to the right place within that hour is paramount. And with strokes, if you have a really high blood pressure, like 250 over whatever,
160.
That is very dangerous. I don't think we need to go on a scenic tour to a hospital 40 minutes away. And I've had patients argue with me like, hey, I don't want to go there because I don't like the hospital. And I never understood that. I feel like people expect hospitals to just save everyone, and that's not realistic. Not all the time can you save them. They may already have medical issues before they went to the hospital. They may not be very well about taking care of themselves. So it's not the hospital's fault. Can the hospital be negligent? Yes, right? Anybody can. But I think it's a little bit unfair to say, well, this hospital's bad, they kill people. Well, people die at every hospital.
By every hospital, every day, for a multitude of reasons. And it could just be to the fact that the patient was past the point of saving. Like there's a point that, well, after that golden hour, if you're not getting a treatment that you need, not because the hospital's not giving the treatment, just because it took so long for you to either recognize, A, there's a problem, or B, to get to the hospital in general, that the likelihood of survivability is next to zero. The unfortunate of that is that's not the clinical mindset most people have. And unfortunately, there was a tragedy up in York, Pennsylvania, it was about a month ago, a couple weeks ago, month ago, where a family member had lost a close relative. I don't know if it was brother, fiance, dad, mother. I don't know the entire story, but they came back the day after with a loaded firearm and started shooting at facility staff because they blamed the hospital for not being able to save the person. Unfortunately, EMS and medicine is one of those it's a dangerous job. And we shouldn't have to put ourselves in that position when we're in a closed and clinical environment like a hospital. And if more people understood that we are doing absolutely everything we can to save the patient, but unfortunately, they are going to die. There's nothing anyone can do for it. I know tensions are high and emotions are high, I should say. But everyone needs to just take a breath, take a chill pill, for lack of better, and think about it analytically. I know that's something that's incredibly hard to do when we're in that heightened emotional sense.
Yeah. And that's one of the reasons why hospitals have security. Just for that reason. It really is unfair to put that on the people responding to that call and the hospital. I wish there was a way to kind of bridge that gap. And I think maybe most of it's due to television. Like you got shows like House, this miracle doctor who just fixes everything. And I think people expect that. And medicine is what? Practicing, basically. You're practicing medicine.
It's not a science. It's not an art. It's a practice. We are always trying to learn more about the human body and learn how to take care of it instead of just having this down pat. My mentors always said, the day that you stop learning is the day you need to leave EMS or to leave medicine in general.
And for me and Dean, we have to actually recertify every couple of years. We have to do X amount of hours in education, skills. So we're always learning. There is no absolute. And
I'm
honestly,
doing my recertification this month. Working through my Con Ed, we call it as continual education. So I have 60 hours of Con Ed that I need to complete before I can recertify as a paramedic.
and so, man, Dean, dude, I could go on, and probably I'll probably have you back on here in a little bit, and we'll catch up on some of the space exploration and stuff like that, man, and kind of dive into that. But really, this episode was just to kind of tell people about what we do, what you do, and who you are, man. And if there's anything else you want to talk about, I'll give it to you.
Well, I'll leave everything with this. Just be yourself, people. Love one another and don't cause any trouble. Just be good. Be safe.
Anything about diabetics?
Actually, yeah. Let's talk about that for a second. So, what made this whole change for my health was I was diagnosed as a type 2 diabetic. It was due to weight. So right now, the best thing that any diabetic can do is take your medication, make sure you're eating healthy and eating at appropriate times. If you're insulin dependent, make sure you're using the correct dose of insulin and taking your sugar. If you're not insulin dependent, exercise, work out, and manage it the best you can. Because you will get to a point where your A1C is back to a normal level. Right now, my A1C is a 5.1, which is, I believe that's not even pre-diabetic at this point. And all I'm doing is eating healthy, and I take Mounjaro. So I know most people are like, the Mounjaro is epic. It's not really good. It's helped me get back to a state of normalcy.
Yeah, diet's the biggest one. Yeah, and also if you're diabetic and you have a habit of getting a really low blood sugar, please check your sugar before you go to sleep.
Yes.
Please, because I know it's with diabetes, you can honestly be in a diabetic coma. Like you're playing with fire, just hoping for the best. Like you have to be proactive with checking your blood sugar. And so, Dean, what's a normal blood sugar range?
Normal blood sugar ranges between 80, 75, depending on what studies you're looking at. So between 75 and 96 or 75 and 120. Anything above the 120, you're in the pre-diabetic range. If you're 140 or higher 2 hours after eating, you are in the diabetic range. So you want to be between that 75 and 120 for a normal, healthy adult. Diabetics are different, though. Diabetic can live at 150, 160. I've seen them live at 210, where if their blood pressure drops to a normal range, they are lethargic, cognitively impaired, because that's their normalcy. That's their normal. But no, Trey is absolutely right. Check your sugar. Make sure you're at the position that you can make it throughout the night without crashing out. So sugar, we need sugar to function. We need glucose. Glucose is how our brain works. We can get into that topic a whole other time.
It's food for the brain. It's food for the brain.
Food for the brain. It's, the mitochondria is the powerhouse of the cell for all, the early 2000s high school kids and elementary school kids. The energy of the cell is what's called ATP, adenosine triphosphate. It's made from two specific ingredients, glucose and oxygen. And if you don't have one of those, you don't have ATP production. So without ATP production, the cells can't function. Without the cell not functioning, your brain don't work. Without your brain working, you are unfortunately in a position that is inconducive with life.
Yeah. I'm surprised we didn't go down the anatomy and physiology route. Yeah, we could talk about the islets, the Langerhans, the alpha cells, and all that stuff. But, big thing, guys, is just take care of yourselves. And so what is a dangerous blood sugar, like a low one?
anything under 75 is considered low. But when we get into the danger zones, we're talking the low 60s to, the 20s, right? Because that's the most glucometers can down. Yeah, most glucometers can only read down to 20. But you're in that area. If you're still talking, that is a phenomenal thing, and that surprises every paramedic and every EMT because normally you are unconscious and unresponsive at that time.
And if we cannot get an IV, we are using the IO.
The IO.
And so,
yeah, it's not a good time for the patient or the paramedic. Like, we don't want to hurt people, and unfortunately, IOs hurt because we're displacing the bone marrow inside the bone to allow fluids to be passed through into your system. But yeah, the easiest way is just check your sugar. Watch how much insulin you give everyone, give yourselves, or have your family give you, and make sure you have a good hearty meal that is carb complex, whole grains, proteins, and vegetables. The complex carbs is what's going to help you maintain that glucose level for an extended period of time instead of the quick burst that we'll get with refined sugar or processed grains.
Yeah, the carbs, they last longer versus, yeah, you're right. And last thing, Dean, dude, I love talking to you, man. Drinking and driving. I don't even drink. I don't drink anymore. But I want you all to realize you only get one liver. And Dean, if you want to talk about how the liver functions and how alcohol, what role that plays with that.
So think of the liver as the filter for the body. The kidneys filter out all the nastiness, but it ties in with the liver. Your liver is your main filter. Your kidney is what helps process the urine output, basically. So your liver is getting damaged with these toxins every single time. It's not like one of those throwaway filters that we can just replace and call it a day, like your oil filter in your car. But that's a perfect example and representation of what the liver does. It's the filter for your body. And alcohol is a toxin. High sugar is a toxin. Fat can be a toxin if it gets into the liver. It's called fatty liver. I still partake in some alcohol myself. I enjoy a beer every once in a while. I enjoy a whiskey when I'm eating dinner, especially out with friends. But I only ever have one with a meal. I never have 2, 3, or 4. And if I'm having 2, 3, or 4, I am not driving whatsoever. I will pay $150 to get an Uber from wherever I'm to my apartment before I get into a vehicle behind a wheel inebriated. I've been on too many accident scenes. I've been on too many fatalities to ever think about putting anyone else in my position in the situation to show up at my accident. I have some personal experience, not myself, but with my family. I'm not going to get into today of alcoholism, drinking and driving, and just the effects that can have. If we all can just agree to not drink and drive, get an Uber, they're normally like $20, $30. Instead of having that last 2 beers that you have at the club, put that money towards an Uber. Take that safe ride home instead of that possibly last ride that you would take, or being the cause of someone else's last ride.
Yeah. And alcohol, it alters your mind. And I think a lot of times when people drink and drive, number one, they're not in the right state of mind and they think they're invincible. It's really sad, man. Yeah, if you're going to drink, do it responsibly. Like, just don't go get behind a wheel, like, because we're the guys that show up to this crap, and I'm gonna be pissed off.
Yeah,
I'm gonna be pissed, and you killed a whole family. I'm gonna be very pissed.
We had a crash out in my hometown. It's a 54-year-old mother of 2. She was going home from work. She was working the Dollar General or the Family Dollar. Driving home at night, everything was fine. She was going home to see her family. She had groceries in the back. I remember that. A white BMW comes screaming down the road doing 85, 90 in a 65 mile an hour zone. Guy is drunk as a skunk, high as a kite, smashes head on into her. She is dead on impact and half burns up in the car when it catches fire. The guy in the BMW walks away scot-free, a couple bumps and bruises. So,
Were there ever charges on that, or?
absolutely. They were definitely charges. He is, I think it was it's definitely either vehicular manslaughter or something higher was the initial charge that came from that. But yeah, he messed up his entire life. I think he was like 19. Messed up his entire rest of his life because he decided to get behind the wheel and messed up an entire family.
Everybody has a phone. Just get an Uber or have a friend. I mean, it's not worth it. Even though you may be 10 minutes from your house, that could be 10 minutes, your last 10 minutes on this planet, doing something stupid like that.
And then you either try or I show up and ask what happened.
I would just be like, why? Why? And so, Dean, man, I love talking to you, man. Like, just you've encouraged me just talking about your story, your struggles with PTSD, and just being transparent, dude. I really appreciate that. I'm sure I'll see you in the next couple of days, man. And you enjoy your time off, brother. And take care of yourself, man. And thank you for coming on. I really appreciate it.
Thank you for having me, Trey. This was great. I always enjoy talking with you and hanging out with you. So I'll definitely see you sometime this weekend while we're both on shift.
Okay, brother, man.
To everyone else out there, I will give you my trademark send off of be safe. And if you can't be safe, be careful.
Absolutely. Thank you, brother. I'll talk to you and catch you later, man.
See you, man.